Good afternoon, everyone. Welcome to the provision of psychotherapy with individuals with IDD webinar. My name is Megan. I'm going to be monitoring the chat for technical issues this afternoon during the presentation. I did just want to let you all know, for those of you who will need CEU credits, you're going to be receiving an email about an hour after the webinar's conclusion. That's going to have a link to the DoDD My Learning website, as well as an enrollment key to get you in there, finish your survey, and get that credit. With no further ado, I'll turn it over to Carol.
Hi, it's so nice to see you all here today. My name is Carol Jackson. I'm a licensed independent social worker and also a therapist. And just a little bit about myself and why I'm here doing this webinar. For about 16 years, I worked for the Montgomery County Board of Developmental Disabilities, where they have a really, really cool mental health program. And I worked there managing that program, and I had a caseload of individuals that I did psychotherapy with, and I came to be very passionate about this population and just really believing that they deserve to have the same high quality psychotherapy services that anyone in the general population would get. So I'm here to give sort of a broad overview because we only have an hour. I'm going to try to cover a lot of different things. As I was thinking about this presentation, I was remembering what it was like for me when I came into that system. I was only familiar with the mental health system. I didn't know how things worked in, with county boards or just anything about, I think, what that system looked like. So it was a huge learning curve for me. And so trying to think through some of the things that might have been helpful for me when I first came in the door. And then I talked to some other therapists about like if they were going to work with someone from this population, things that they would want to know. So I'm hoping that I put together some information that'll be helpful for any mental health providers out there who want to work with this population. So I'm just going to get started. So to begin with, like we know that there are just a lot of myths out there and misperceptions about the benefits of psychotherapy for this population. And really, there's a reason why it's that way. For a long time, there wasn't that much research about, how do you work with this population. A lot of misperceptions were out there, like from the 1950s to the 1980s. The research that was done basically was telling therapists that there really was no benefit to psychotherapy and that people's outcomes would be the same whether they participated in psychotherapy or not. Which, of course, like if you're a therapist and you're reading the literature and you're hearing that, it's really going to inform like your views about working with this population. And I think probably at the time, I don't know a lot about that research and like exactly how it was being completed, but I'm guessing that some of the modifications and adaptations that we know can really increase the efficacy for this population probably weren't being made when they were looking at how effective it is or isn't. And then, there was also this belief that whether they could benefit from therapy or not, that actually like somehow having their intellectual or developmental disability somehow made them immune from developing mental illness, kind of believing that it protected them from developing mental health disorder, and that, somehow like your cognitive disabilities would actually prevent you from experiencing some emotional discord or stress. And then also I think there was, and maybe to this day it continues a little bit, like a belief that folks with ID don't possess the necessary skills to actively participate because of their diminished ability to use abstract reasoning. Then I think sometimes it can be assumed that they don't have the skills that they need to explore their own behavior or actions, or to explore potential triggers for things that are going on, or to understand the benefits of making positive change. I think I'm having a little trouble with my slides. It seems to have frozen. So I'm going to restart it real quick. I'm so sorry about that. I'm not sure what happened. Okay. One second. Okay, hopefully that fixed it. Okay. But we now understand that psychotherapy actually is the best practice. Oh, I think I lost it again. Megan, can people see the PowerPoint?
Yes, I can see the PowerPoint.
Okay. And you see me moving
So
through it.
everything,
Everything's fine?
yeah, looks like I've got a couple confirmations in the questions box saying they can see the slides as well.
Okay. It looks like it's frozen. So, okay. So sorry about that, everybody. I just wanted to make sure you guys could see the slides. So what we now know is that individuals who have intellectual disabilities actually do experience mental illness at rates that are much higher than what you find in the general population. So, and we think that that happens for a variety of reasons. You know, folks who have developmental disabilities can be more vulnerable to stress. Sometimes they have sort of lack of coping skills and knowing how to process and cope with life stressors or distress when it occurs. And oftentimes they have a smaller set of natural supports that sort of also, you know, those are often a protective factor for folks. And this population sometimes is lacking in that area. So for the general population, the experience of a mental health disorder tends to be about 20% or somewhere around like 1 in 5 people will experience some type of mental health disorder like in any given year. And estimates vary with this population, but the incident rates are much higher. Like there's somewhere between, I've read as low as 30, and I've seen as high as 70 in the different research that I've looked at. So let's just say like somewhere between 40 and 70%, which is really high. So we know that actually like this population is very vulnerable to stress, has a high rate of you know, experience of mental health disorders. We know that actually intelligence is not the sole indicator for appropriateness of therapy. You know, participation in mental health treatment can and does improve overall quality of life for these folks, just like it would for anyone in the general population. And, you know, they can reach the same goals, stabilize symptoms of mental illness, improve their ability to express their feelings and emotions, improve their ability to cope with life stressors, just to develop those coping skills, improve how they see themselves, you know, in the world around them. So there are so many reasons why this is the best practice and why, you know, people who have intellectual disabilities are really needing therapists who are like excited to work with this population and make sure that they do get those quality services. So I wanted to talk just briefly. I want to go through this information pretty quickly, but I just know most folks in the mental health world don't know a lot about the ID system and how that all works. So I thought it would be helpful just real quickly to sort of just go through and make sure that everyone's familiar. And I think this information is really helpful, like if you're going to work with somebody in this population, and particularly somebody who's receiving services from a county board. So these are the ranges of ID. Mild ID is between 50 to 55 to 70. Moderate ID is 35 to 40 to 50 to 55. Severe ID is 20 to 25 to 34 to 40, and profound is below 20 or 25. So most of the population who has an intellectual disability actually will have mild ID. It's about 85% of folks with ID have mild ID, and about 10% have moderate, 3 to 4% have severe, and 1 to 2% have profound or below. So the folks that you probably would typically see in your office will have mild and maybe moderate intellectual disability. And Dr. Gentili did a fantastic job of sort of describing the cognitive capabilities of individuals with ID using Piaget's stages of development in a book that she published maybe last year or the year before that, which is the Psychiatry of Intellectual Disability, which I think I have it in the end in the references. It's a great book. It has so much good information in it, but the information around this is in there for sure. And I think that these explanations can be really useful to therapists to help understand like the level of understanding a person with ID might have, so that you can adjust your interviewing and therapeutic interventions to kind of match those needs of the person that you're going to be working with. So mild ID would typically be functioning at the cognitive level of concrete operations. So those folks are going to think logically about concrete events, but have trouble sort of understanding more abstract or hypothetical concepts. They're not able to use deductive logic, but they are able to use inductive logic. They might have some trouble describing their symptoms. So, for example, like someone might say that they are like scared instead of mad. They might not have a language for how to describe their symptoms. And they're going to be less egocentric than people who have more severe disabilities, so more able and capable of beginning to see things from other people's perspectives. Folks with moderate ID are functioning at what we think of as the pre-operational stage. So these folks are very concrete and literal understanding of the world and of things that are happening to them. They are much more egocentric and tend to see things from their own perspective. So they might have trouble, like if you're like working with someone and you want them to understand, maybe there's something going on in their interpersonal relationships, and maybe they're teasing someone or not being kind to someone, and they might struggle to understand if you're trying to talk to them about like how do you think Sally feels when, you know, like you tease her or you say those things to her. That person might really kind of struggle to understand things from Sally's perspective. So it's important, I think, to understand that like when you're working with folks with moderate ID, so you can sort of adjust the intervention that you're doing, so you can still address those issues, but understanding you're going to have to work around that issue. They also may have difficulties with manipulating information and drawing logical conclusions. The severe and profound folks are functioning at the sensory-motor stage of development. So these folks have a really limited development of language, and the mental concepts that are formed are simple and often irreversible. So these folks definitely can experience mental health disorders and need access to quality mental health care, but it might not be talk therapy. It might be more appropriate for these folks to have some maybe intensive case management and definitely to see a psychiatrist for help with their symptoms, but they might not be great candidates for like talk psychotherapy. So I want to talk just a little bit about the county boards of DD, just to make sure that you have an understanding of that. So in Ohio, our county boards provide assessment, service planning, and coordination to adults and children with developmental disabilities. I know before I started working for the board, I really didn't have an understanding of like how someone would qualify for services. I think I thought maybe at the time that it was enough just to have a qualifying diagnosis, but it's not, it's more than that. So I thought it would be just helpful to just quickly go over that. So qualifying diagnosis is part of it, but it's not everything. But the qualifying diagnosis has to meet these criteria here on this slide. So attributable to a mental or physical impairment or a combination of mental and physical impairment. And it can't be an impairment that was caused solely by mental illness. It has to have manifested before the person turned 22, and it has to be likely to continue indefinitely. But more than that, that diagnosis has to also result in one of the following. So folks also have to have functional limitations in at least 3 of the following areas of major life activity. So self-care, receptive and expressive language, learning, mobility, self-direction, capacity for independent living, and if you're 16 or older, also capacity for economic self-sufficiency. So if somebody meets all of this criteria and the board deems them eligible for services, then they are eligible for a wide variety of services that they could be receiving from the board. And so I think it's important as you're working with someone to know whether they're eligible for county board services, and if they are, to know which of those services are they getting. These are common members of the multidisciplinary team that might be sort of like a part of that DD world. So the first one is a service and support administrator who functions as like the single point of contact for folks. It's the person that develops their ISP in the DD system and makes sure that they're receiving all of the services and supports that they need to make sure that they're safe and that they're healthy and that all of their needs are met. Folks also could have a behavior support specialist who also would be employed by the board, and they also could have other folks sort of involved with them. Folks might live in a group home, so they have a group home manager that works with them. They might go to a work center. They could work in the community, but they also could work in a more structured center where there's a work supervisor. And I just mention these people because as you're providing services, each of these people might be a really valuable source of collateral information, which could be really important. So it's just a good idea to sort of have an idea of who's all involved with the person that you're going to be working with. And the SSA will, in a lot of cases, might be the person who initiates the referral for mental health. And regardless, we'll want to know what services that you're providing as a therapist, because those mental health services will be documented in their in the ISP that they have to do for those county board services. So I want to talk a little bit about the barriers for treatment that folks often see when they, the reason why we have access issues. So I think sometimes folks are just sort of caught between the two systems, between the mental health and the DD service system. A lot of times, I think people in the mental health world don't understand what is or isn't available in the DD world, and might think that once they're receiving DD services, that mental health services are a part of that. There are some boards that have mental health programs, but not many. I think Montgomery County was the first of the 88 counties in Ohio to do that. And since then, I think there are a handful of others. But a lot of times the boards really depend on community mental health providers to be able to step up and work with this population. And a lot of times folks in the DD world don't really know how the mental health system works or how to access those services. So I think sometimes that can be a pretty big issue all by itself. And a lot of times mental health therapists feel that they don't have the education and the training to work with this population. Most of the time, when you're in college and graduate school, there aren't classes on best practices with this population, and folks might not have had a lot of experience working with someone with ID. So I think it can feel sort of scary to work with this population when they feel like they don't know a lot about it. And then also individuals with ID seek professional help less often, and that can be for a variety of reasons. One is that folks with ID often just have like a lack of experience with or information about mental health treatment. So not really even knowing, that it's out there, what it is, that's an option for them. And sometimes people involved with their care also they might be undertrained in mental health issues in this population, so might miss symptoms as they're occurring. And then maybe they do realize that they don't know how to find someone who really knows how to work with this population. And then lastly, just that it's difficult to find a treatment that really meets the specialized need of this population. So I think all of those things sort of lend itself to making it a little bit more difficult for folks to access good care. And honestly, the provision of psychotherapy is a little bit more difficult, certainly more complex. Folks with ID often have communication issues, and those do have a significant impact and have to be addressed. And the mental health symptoms can present much differently than they do in the general population, or they could be more subtle. So for example, someone with anxiety might report feeling physically sick when really they're feeling anxious, and so they're having the stomach upset and some of the physiological symptoms that can happen, and that's what they recognize, but they're not able to identify the emotions or feelings that are coming with that. And then lastly, just the presentation can become more atypical as the severity of ID increases. So that often leads to diagnostic difficulties, including diagnostic overshadowing, which diagnostic overshadowing occurs when a mental health professional makes the assumption that a person's behavior is just like a behavior and part of their disability, versus it being representative of some type of mental health struggle, which it very well might be. So sometimes when we're assessing folks with intellectual disability, that the fact that they have that disability becomes just like the obvious characteristic that we're focusing on, and then it sort of interferes with our ability to really see the signs of emotional or mental illness. And some of that, I think, can occur sometimes because the language that folks use in both worlds can be very different. A lot of times people in the DD world do refer to people's, what we might think of as mental health symptoms as behaviors. And I think that can be really confusing to a mental health person when somebody presents to them for treatment. And when I worked for the board, for example, one of the things I would try to talk to group home staff about, they had somebody who, let's say, really struggled with depression and needed to go to the hospital to be evaluated for hospitalization. To when you take somebody to the ER, not to use the word behavior, not to say this person is having these behaviors, because a lot of times that is what would happen, and then the social worker or the mental health person in the ER would just assume that you're talking about some type of baseline behavior that's just part of their ID and not something that could improve with psychiatric hospitalization. So people would be dismissed from the ER pretty quickly. So trying to train staff about what the mental health symptoms were versus behaviors, and to make sure that they're using that language when they're talking to a mental health person about those symptoms. So just a word about that. I think a lot of times there is a lack of understanding of the maladaptive behaviors that sometimes can occur with folks who have intellectual disabilities. So the maladaptive behavior is any behavior that's frequent or severe enough to significantly impact somebody's functioning. And it could look like a lot of different things. I listed some of the things here: physical aggression, self-interest behavior, hitting yourself in the head, or banging your head on the wall, stereotypical behavior, like rocking, or sexually inappropriate behavior sometimes. So, there's been a lot of different research on this topic, and I think the prevalence of maladaptive behavior in individuals with ID is somewhere around like 60 to 65%. So like a high number of folks with ID will engage in some type of maladaptive behaviors, but it's important that we don't just dismiss them as just being part of someone's intellectual disability, because sometimes it is. Sometimes it is just part of someone's baseline functioning, and when you get the history and you look through like the person's life, and if it's something that's been happening for 10 or 15 years, and this is how the person functions, that's one thing. But it's also important to look to see if there's been any increase in the severity or frequency of the behavior, even if it's something that's been happening for a long time, but right now it's happening at a higher rate, or whatever's happening is just it's a little bit more significant than it was before. Then that really can be that can happen because there's a mental health issue that's occurring, and sometimes a new behavior that looks like it, like it's just a typical maladaptive behavior that, but it's new, like it didn't present before, and sometimes that can be caused by the mental health issue that the person is experiencing. So it's important to have a sense of what someone's baseline is if they are a person that engages in maladaptive behavior, and not to just dismiss it outright, to really think about that. Is there any increase in the severity or frequency of what's going on, or is this a new behavior? I had an example of that. I might, throughout this presentation, just talk a little bit about cases that I worked with, but if I do, I just want to assure you everyone's de-identified and information has changed so that they're not recognizable. But I had a client who was biting themselves, and pretty significantly on their arms and their shoulders, and the family was really not able to vocalize like what the triggers could be. They were trying to pay attention to see what was going on, like right before the behavior occurred. They really weren't sure, and the client themselves, they were not able to really voice that with me initially. And it took actually a long time of us working on other issues and really developing rapport, and for this person to feel really safe with me, for eventually the person to share that there was some domestic violence that was happening in the home, and the biting was actually happening just after something like that had happened in the home, or when they were away from one of their caregivers out of anxiety that something might happen to them. So, I think when I first met the person, there's no way that they were going to share that with me at first. So I just really tried to pay attention to it. I kept trying to sort of figure it out, what was going on, and I never dismissed it, always took it really seriously until we could figure out what was the underlying cause of that. So I wanted to talk a little bit about why the rates of mental illness are so high in this population. And there's lots of different reasons for that. One is that they're just, they have a high susceptibility to stress. So like how you experience stress depends so much on your locus of control. So folks that have an internal locus of control, where you feel like you have a lot of choice in your life and control over the circumstances of your life, tend to have less stress than folks who have more of an external locus of control, where you feel more at the mercy of events that are happening to you, and can get kind of stuck when exposed to those kinds of stressors because it feels like you're powerless to do anything about it or to make a choice that's going to be helpful, and so it just leads to higher rates of stress and a sense of helplessness. And folks with intellectual disability often really have that external locus of control. There are a lot of things in their life that they have a very limited amount of control over, even though the goal is always to help them have control over their life choices. But some things, there just can be times where there just is little say, like where they live in a group home might just depend on where there are openings, whether you really like the housemates you end up with or not. You might, I definitely have worked with people who were placed in a group home where they really just didn't like their housemates, and so it was very difficult for them, but there just weren't other openings or, opportunities to go somewhere else. Sometimes people really want pets and might live in a group home where that's just not possible. They might not have a lot of choice over where they work. There's just so many things, that can be sort of outside of their control. Also, there tends to be a lack of social supports in relationships. Like they can have friends, but a lot of times those friends are more sort of superficial relationships, and they tend to lack sort of the deeper emotionally intimate connections that a lot of times can be protective when you experience life stressors. And often they have poor problem solving or coping strategies, so that when the stress occurs, they don't really know what to do with it, or how to handle it in a way that would make it feel more manageable. Transition periods can also be a time of a great deal of stress for folks. And a transition period could be anything from you're transitioning from a school program to a work program, or you were living with your family and now you're moving into a supported residential environment. There's just so much change that's involved in that, and we know that change, all kinds of change, even positive change, even if you're looking forward to moving away from your family home into a group home because you want to be more independent, it's a lot of change. You have to get used to a lot of new things, and just folks with ID tend to have so many of those types of transitions throughout their lives, which can be very stressful and sometimes can even trigger grief and loss issues. And they also might feel stressed as family members experience their own transitional periods. So, for example, I've worked with folks who, lived at home with their 3 siblings, until their siblings were of college age, and then they went off to college and, after college, met somebody, got married, started to have children, and then the client might be really struggling with that. Those might be things that the client wishes that they could do, that just feel so out of reach for them, that they can't reach those same milestones. And so that can be very difficult. And sometimes they can just feel left behind, that they really enjoyed that time when the entire family was home and they had their siblings, and it can feel like their siblings have just kind of moved on and abandoned them in a way. So that can also trigger feelings of grief and loss. And I just wanted to touch on grief and loss as an issue just by itself, because folks with ID tend to be particularly affected by it. And some of that I've just touched on, just the many losses throughout the lifespan, some of that just being with the changes that can happen. So an example of that is just as you're having those transitions maybe, and you're going from a school environment to a work environment, or maybe you're at work, but a supervisor leaves, changes jobs, or, goes to do something else. And for most of us, if we have a job and our boss leaves, that could, if we're really close to our boss, that could be a little sad, and then we adjust and move on. But these folks have much stronger bonds with the folks that they're working with. You know, they are dependent on them for their well-being and safety. So these relationships often have a great deal of meaning and an attachment for them. And then there really can be frequent staff turnover, a lot of times happening without a lot of notice or sometimes without notice. You know, so it can just mean the very abrupt end to a relationship that felt very significant for the person. And they also can, you know, just experience the changes with like friends leaving and deciding to go work somewhere else, or, you know, and if you already have a limited social group and maybe, you know, there are one or two people at work that you were really close to, and then a person leaves, that can be actually like very, very traumatic for a person, you know. And the loss of parents sometimes is also like particularly difficult, and in part that can be just because of the nature of the relationship can be a little different. A lot of times, folks with ID are living with their parents for much longer than the average person. Like their parents might be caring for them well into the client's like middle age or even older. So they're, you know, that's just become their life. Like their parent is like their best friend, their strongest bond. The person's always been there for them, and so when their parent passes away, that can just be particularly difficult. And it also can trigger some of those other losses that we talked about, just in terms of like if your parent dies and you were living in that family home, now you have to maybe move to a group home, so you have to move to a different neighborhood, and you're losing the familiarity of the home that you lived in and the neighborhood that you grew up in, and maybe you had friends in the neighborhood or people who were friendly, and so now like everything is different, and that can be difficult, and it can take a long time to adjust to. And again, because folks often have a limited number of natural supports, those changes can just be even more difficult for people to manage. They don't have those relationships necessarily to fall back on. Trauma is also an issue that is just something that as a therapist working with someone with ID, just to be aware of. The fact that folks with ID are so often dependent on their caregivers for their well-being and protection can make them particularly vulnerable to a wide array of abuse. Research indicates that they experience abuse, particularly sexual abuse, at rates that are significantly higher than what's found in the general population. I've read studies that have indicated that as many as 90% of people with ID will experience some type of abuse sometime during their lifetime. And they can be particularly at risk for a variety of reasons, limited verbal skills, so they cannot alert someone to what is going on, maybe a lack of understanding of what is even happening to them, not understanding whether something is appropriate or not appropriate, like maybe feeling uncomfortable with something, but not knowing like where the boundaries should be, fear of consequences for speaking up, you know, not really knowing what will happen if you share that information, and a real need to please and be accepted by the abuser. And all of those things can put people at risk and make it very difficult for them to get the help that they need after that kind of abuse happens. Also, sometimes just having the disability in and of itself can be difficult for folks. You know, we all know that there are still societal stigmas about having a diagnosis of intellectual disability, and that just sometimes has a devastating effect on folks. They can internalize those messages, and really it can cause low self-esteem and feelings of inadequacy, depression. It tends to be folks who have more mild intellectual disability that are more susceptible to this. They tend to have just an increased awareness and understanding of the fact that they have a disability, and then all of the prejudices that are sort of associated with it. Oftentimes, they really long for a level of independence that just feels like it's like out of their grasp. They might need support with like managing their finances, finding and maintaining employment, just navigating activities of daily living. They might need help like getting to a park or just whatever that they might want to do. They might need someone's help in doing it. And that can be really difficult for folks who just wish that they could do things, by themselves on their own. So it really can impact their sense of self-worth, and would be really important issue to be addressed in therapy. I've worked with folks who really like wanted to experience dating, for example, and so locked their group home staff out of the apartment they were living in so that they could try to get on the internet and meet men and have men come over, because they wanted to date. But then what happens is somebody wants to come over to take advantage of a person. And in the case I'm thinking of, took money and took things out of the apartment. So it's just, but that came from a place of just wanting to be independent and being a 20-something-year-old person and wanting to date and do what they felt, was age appropriate for them. So prior to the first appointment, I think it's really important to really take a look at the records so that you have an understanding of the person before you work with them. I know typically, as mental health professionals, we like to sort of have a blank slate before we work with someone and maybe not know a lot of information about them ahead of time so that we're not biased. But this population, because of their particular needs, it really is important that you get as much information ahead of time as you can to help you with your clinical impressions and really sort of understanding the unique needs of the person so that you can try to get a handle on how you're going to address that before you see them and you're not surprised by that. So a really helpful thing to do is to review, obviously the mental health assessment that was done, but if there are prior psychological assessments, that's helpful. Health assessments are important. Sometimes folks can be struggling with health issues that can kind of manifest as behaviors when really it's like a health issue going on. So you just want to make sure that you're sort of aware of what someone's diagnosis is and kind of what's going on in their life, what their baseline behavior looks like, really have an understanding of like the presenting problem and how new it is for the person or isn't. So it's also a good idea as you're doing that to really identify like where does the person live and who's the point person there, because they could be a really important collateral data source for you, and to get a sense of what coping strategies are potentially available to the person already, like just in their environment, so that you could use supportive interventions to sort of like shore up those helpful things that maybe are already occurring or could be occurring. And that can help you to sort of, have something positive going on that's helpful right now, to give you time to really work with the person in therapy to develop additional skills and strategies to help manage things. And as you're thinking through and getting ready to see the person, I think it's important just to be aware of and prepare for communication issues that can occur. So one of the most important things that just to be aware of that can happen is acquiescence and masking. So acquiescence is the tendency to want to agree with any statement that's given to them. And masking a lot of times is just sort of trying to hide the fact that someone has any problems with their expressive language skills, or receptive language skills, wanting to appear like they're really understanding things, sort of hide the fact that they have a disability. So then you have to be sort of cautious with the responses that you're getting in response to the questions that you're asking, just knowing that they could just be wanting to please you or be afraid of consequences if they don't, or if they share something that they shouldn't. And it also sometimes can happen if the questions that you're asking or the language that you're using is just too complex for them to understand. And so just really wanting to sort of appear like they do when they don't really. So, and this is actually negatively correlated with IQ. So the higher somebody's functioning level is, the more likely they are to try to kind of fit in and acquiesce and mask. So when you're working, especially with someone with mild ID, to really kind of pay attention to see if these things are going on. Masking can also look like just like statements that a person has learned, that when somebody asks them a question, that they just sort of they have learned this statement. It seems to get them by, so they just say it, but it's not actually like maybe how they're feeling, or could just be learned behaviors to just fit in, or get someone just to leave them alone. So some strategies to really help with that is, one is just to be alert to any inconsistencies that are happening. So like when someone's telling you a story, what they're saying and then what their body language looks like, that really sometimes could be an indicator to you that if there's like a real difference between what they're saying and what they would say if they felt like they were able to or empowered to. Just be honest in that moment. And also just working slowly with the person, like repeating yourself if you need to, checking for understanding throughout the session, just to make sure that you're not over or underestimating what they understand. And it's also really important that you're not yourself pretending to understand what the person is saying when you aren't sure, because you don't want to offend the person. It's really much better just to gently kind of check it out than to assume that you know and then just be way off the mark and have the person feel really unheard. You also just want to help the person feel comfortable with you. That will really help a person feel like they can be honest and open with you. So some of that is just, like the obvious things that you would be doing as you're building rapport, treating them like a person. If they're an adult, that you're treating them like an adult, not like a child. That you're not speaking to them in a way that feels insulting or degrading. So just speak naturally, use age-appropriate tone of voice, and know that eye contact could be difficult for some people. So making them comfortable might look like, instead of sitting across from them like you traditionally might do in your office, that maybe you're sitting side by side. Maybe you start off playing a game, or just chatting with them about their interests, but just really taking time to help people just feel comfortable, and making sure that your communication is as it's matching theirs, so that you use their words as much as possible, that you match their mean length of utterance, so that your sentences have as many words in it sort of as they do, that your speech is matching theirs, and that you're using simple languages and sentences that aren't too complicated. Sequencing is something just to be aware of, because folks with ID often have difficulty with this. And so this can be challenging, like when someone's sometimes trying to tell you a story and it might come out of order or might seem illogical. So it's just important to remember that they might just have trouble with saying things or sharing things with you in a way that seems to chronologically make sense. So it's just important, if that happens, just to be really patient, let the person tell their story in their own way, in their own time, in full, without interrupting. Eventually, you'll you'll figure it out. You just have to be patient with that, and know that it can vary a great deal between people. I've definitely had clients who had great difficulties staying in chronological order as they told their story, and then other people who would have felt like great discomfort if they were interrupted or had to tell their story out of sequence. So just important to be patient, and just remember that someone might need a number of sessions to share the story that they're trying to tell you. And when that's happened to me, I just think, I take my time and just remember that it's my job to just, remember what I've heard, pay attention to it, and then attempt to make sense of it as a whole. So also to be thoughtful in how questions are presented. Complex questions can create a lot of confusion and embarrassment for the reasons I talked about earlier, and really trigger that need to sort of look like they understand things when they don't. So you just want to make sure that you're keeping your questions simple. Don't ever ask two questions about different subjects in one sentence. Make sure that those are two separate questions. Avoid the use of negative and double negative questions. Avoid leading questions. For sure, if they want to please you and they think that you're wanting a certain answer, you're going to get that answer. And sometimes using a combination of open and closed questions can be really helpful. So like you open with an open question, like what would you like to tell me about your family? And then ask closed questions to confirm the details or clarify the meaning, like, and do you have an uncle? And just sort of slowly work your way through. Many people with intellectual disabilities experience short attention span. They may struggle with gaps in their memory. They could have difficulties with memory processing. So, really and that can vary so much between individuals. So you'll just have to assess the person's ability to focus and remember, but also remember that anxiety before and within the psychotherapy session is very common with this population. I think there can be a lot of pressure because therapy is talk-based, coupled with their struggle with communication can feel like a lot of pressure, and then that anxiety can impact on a person's attention and concentration. So, someone could come in and really be struggling with those issues and just tell you like that they don't have anything to talk about, everything's fine, they're fine. They really might not remember the things that have gone on before that maybe would be helpful to talk about. Or they might talk about a particular topic or an experience that seems really unrelated to the session and maybe what you were talking before. So just be mindful and try to be where the client is and adjust what you're doing, to whatever their needs are, versus you having an agenda of what you want to make sure that you're covering and doing. And there's where like a person who comes in and you really know that there's something that they struggle with, getting that collateral information from people around them to kind of know what's been going on can really help with that, because you can bring up things then and see if those are issues that they feel are important and that they'd like to explore. So for the initial appointment, just paying attention to the fact that you're aware of how the referral process works. Often folks are not self-referred, somebody else made the referral. A lot of times that's because there was some kind of maladaptive behavior that occurred. So folks might be there, but it really very well might feel like it's a consequence or they're in trouble in some way, versus it being like an opportunity for self-growth and discovery and positive change. And because they just might not know a lot about mental health, they really might have a lot of confusion about the purpose of mental health services and why they're even there to see you. So it's just really important in that first session that you make sure that you sort of have a conversation about that, about their understanding of why that they were referred. If you do get a sense that maybe it feels like they're in trouble in some way, that they get some reassurance that they're not being punished, and just some general education about what psychotherapy is, you know, explaining to them like the purpose and why people go, just so that they can start to have a sense of what's going to happen. And they really might need to know in a very concrete way, like what you're expecting from them and what they can expect from you in sessions, you know, so really like explaining to them that they might be sharing about all different areas of their life. You might be doing some skill development with them, role playing, you know, and that you're just very clear regarding both of your roles and the expectations for both of you. And
Hi, Carol.
there,
Oh,
yeah.
sorry, I just wanted to interrupt for just one moment because we are coming right up on our scheduled end time. I didn't know if you wanted to continue the presentation, and if that's the case, folks can always follow the registration link to watch a complete video of this. You'll still receive, okay.
Yeah, I'm just going to finish it so that it's out there.
Oh, fantastic. All right.
Okay.
So again, everyone watching, if you want to watch the complete presentation later on, the registration link that you use, that will become a link to an archived version of the video so you can watch the complete thing.
Okay, so, and I apologize. I think my computer issues earlier threw me off schedule. So it's important during that first session that you're also just addressing the communication very openly, you know, that you make it a very neutral and legitimate topic of discussion, exploration, that you want to make sure that they understand what's being said to them, and you want to make sure that they feel comfortable letting you know if they don't. So it's just important that you're having that conversation and negotiating that, and being sure that you're not overestimating their abilities. Make sure that you're using plain, simple English, avoid any professional jargon, pace your communication, use repetition, and just be sure that you're speaking in very concrete terms that would be easily understandable. If there is trouble, make sure that you take responsibility for that, that you take responsibility in the beginning, like, you know, it's your job as a therapist to make sure that the person understands what you're saying, and that you want to make sure you understand what they're saying. So if there's any thing that you don't, you're going to ask them, and you want to be sure if there's something they don't understand that they ask you, and let them know. You'll be checking throughout the session just to make sure you guys are on the same page. And then as things happen in the session, you know, like if you falter trying to form a clear question and realize maybe that you did a double barrel question, or, you know, something that maybe wasn't as clear, just to apologize for that. Like, oh, I'm sorry, that was confusing. Like, that's my fault. Let me start again. Or just reset the question. Let's go back to the part where you were talking about your mom. Let's start there. And if the conversation gets too confusing for either you or the person, just start over. Just make that very explicit and say, I think I'm very confused about this. Let's start over. Let's start from the beginning. Addressing confidentiality is also really important with this population. Obviously, it's always an important part of the psychotherapy process, and individuals with ID have the same needs as the general population does. However, like for these folks, it's a little more touchy. It is the norm a lot of times for folks with ID to kind of witness their personal information being shared between other professionals involved in their care, in different meetings that they might have, or things that are happening at home or at work. So they might assume that those same kind of breaches will happen with you, and so withhold information out of fear of judgment, or that like maybe their issue is like with their group home manager, and they're afraid that if they tell you that the group home manager is going to find out that, and then there'll be consequences in their environment because of it. So it's just really important to provide education regarding the you know, just the importance of confidentiality in the therapeutic relationship, and why and how it protects them and ensures for their privacy, and really to help them understand how your role as a therapist is different from that of the other providers of care that they work with. And this can be complicated because there are a lot of different providers often involved, and you actually will probably need to or should touch base with some of them at different points. So it's important just to talk about that up front as a part of that confidentiality process. That, for example, there could be times when you touch base with the home manager touches base with you, but letting the person know that, what that would look like, what you would share, what you wouldn't share. Like, for example, with me, I would always tell a person, you know, like, if I'm going to talk to your home manager, I'm always going to talk to you about that first. We'll talk about what's going to be shared and what's not going to be shared, and I'll only share things with your permission to do so. So just so that they're clear that it could happen, but that they're still very much, in charge of what that looks like when it does happen. Some other therapeutic issues to just consider as you're working with someone who has intellectual disabilities. The first thing is based on kind of like what we were talking about before about the acquiescence and the masking, and just the anxiety that people might experience when they're engaging in therapy, with the pressure that they might feel. It's just so important to help them just feel comfortable with you in general. And that actually might take a long time. It might not just be like one session. It might be multiple sessions of you really building trust and that person really seeing how this relationship is different, and that you really aren't sharing that information with other people, and you know that they can really feel safe. But some things that you could do to sort of help lower the experience of stress in sessions would be to like maybe walk and talk with someone, to play games maybe during sessions. Like if I had a person that was like super anxious, like maybe we would draw while we talked if the person loved to draw, or I had someone who really loved to play Uno, so we would always just play Uno. And in the playing of the Uno, a lot of times we would talk about really important things. So sometimes I think that is necessary throughout the whole session, and sometimes maybe it's something that you do in the beginning of every session, so they know that they're going to come in and that's what's going to happen first, and then you're going to ease into the deeper work. Don't be afraid to openly address their experience with having a disability. I think it can be so helpful to just talk to them about it, what their beliefs are about having a disability, you know, what kind of messages that they've internalized and what they perceive those to mean, and then work to help them restructure those beliefs and explore ways where they can have some control over their environment, you know, and just be like feel more autonomous, and really help them identify when they do something well, when they're handling something competently, so they can start to identify their strengths, and then it's just the things that they're doing well. They might be missing those things and focusing more on the things that they feel like they're not doing very well. Folks with intellectual disabilities also tend to have a more outer directed orientation, and that's because they're so dependent upon others for their daily functioning. So they really might look to others as a guide for their own behavior versus sort of internally figuring out what they want to do, what would be the best decision for them. So they might follow the cues of others versus acting in a way that's actually like in their own best interest. And it's important to sort of help a person deal with that in a therapeutic way. You really want to help people restore a sense of self-control. So again, like reframing events with the emphasis on their strengths and abilities, so they can think about themselves positively and gain confidence in their ability to make good choices and do what's best for them. Teaching people about appropriate boundaries and expectations in relationships is also really important. So, and how to set those boundaries. And you might need to teach some assertive communication skills around that. And just practicing assertive communication and boundary setting, that do some role play, teach scripts that they could use so that they can start to really use their voice. And a lot of times folks with intellectual disabilities struggle with expressing their emotions. So it's important to explore and assess how a person describes their feelings. How well are they able to do that? Do they have any deficits in this area? Not being able to label or communicate your feelings is difficult. It can negatively impact your ability to problem solve or develop options. So this is an important skill you want to make sure people develop. And when you're doing that assessment, if you're finding that they don't really have a language or a means to express their feelings, then you can help with that. You can help them learn words and gestures so that they can express themselves. And a lot of times with this, like using pictures and posters of faces can be helpful just to help people develop just that basic understanding, basic language of their feelings and emotions. And it also can be a good idea to help interpret nonverbal cues or behaviors for the person so that they can identify for themselves. So I gave the example in the very beginning that maybe somebody with anxiety notices that they feel sick, but not that they feel anxious. So they can say, like, I feel sick when they're actually feeling anxious. So helping them identify that so they can put the feeling to it when it's happening. So if someone looks angry, like saying like, oh, you look angry when you're telling me that, it's helping the person learn, oh, okay, like when I feel this way, this is what that is. And then just providing in session opportunities for the individual to relate their feelings. So tell me about a time when you felt sad. Tell me about a time when you felt really worried. And then provide examples of times when you think a person might have experienced a particular feeling, like it sounded like, when you were telling that story about your mom, like you felt really angry when that happened. Again, just really helping them learn how to identify when they're feeling an emotion, what that emotion is, and then how to communicate that. And then there are just several modifications that somebody can use to increase the efficacy of psychotherapy. Really, there are so many modalities that be helpful with this population. Motivational interviewing, DBT, supportive psychotherapy, CBT, any of those would be very effective. I don't think that it's the modality that matters as much. It's really whether you're using the appropriate modifications regardless of the modality. So you'll be more likely to have successful therapeutic interventions when you're flexible in what you're doing and you're really tailoring the interventions you're using for the particular needs of the person in front of you. So flexibility is really important. That traditional treatment model, 1 hour once a week, really might not be a good fit for folks who might have a short attention span and just might not be able to sort of, maintain their focus for a whole hour. So you might find that someone maybe can only tolerate about a 30-minute session. So maybe you need to see them 30 minutes twice a week instead of 1 hour once a week. And it's just important to kind of pay attention to that, or what someone seems like they can do when they're with you, what they can tolerate, and then adjusting what you're offering, just to meet their needs. And meeting more often also can be helpful because of the attention and memory issues. A person might not remember important issues that have happened like a week ago. So meeting more often sometimes can be helpful because someone might be more likely to remember something that just happened 1 or 2 days ago versus 7 days ago. And like I mentioned, they might not be able to tolerate the hour session. A longer length of care is also really necessary with these folks. So research advocates for about 1 to 2 years. I think maybe even longer, probably, with a lot of folks. You just need to make sure that you are allowing time that folks are going to need just for a lot of different things. So there's going to need to be that time in the beginning where you're just providing that education and preparation for the process of therapy, all of the things that we already reviewed that you want to go over and make sure that they understand. You want to make sure that that you have that time to teach them the language that they need so they can express themselves. You need time to work with the person on the actual interventions you're using. You might really spend 2 to 3 sessions, maybe even longer, on just one skill before you move on to the next one. It's really important that you're able to do that you really can slow things down and take your time. Moving too quickly will mean that folks just really aren't absorbing what you're telling them. And so, taking your time, just make sure that people can really internalize that new information. And it also allows for repeated practice with skill development, which is really important to ensure for learning and change. So the more that you can role play and, practice scripts maybe that you've given them, sort of like doing that over and over again, the more likely it is that they're going to be able to use that skill in their natural environment. It's also important that you're paying attention to the interventions that you're giving. Like it says simplification of interventions, and as a whole, you should do that. Also, be cautious of using interventions that are like too simple, but you also don't want them to be too sophisticated. And here again, that really depends on the functioning level of the person that you're working with. I've definitely worked with people with mild ID, where everything about that session looked exactly like it would look for anyone I've ever worked with in the general population. And so making it too simplified would have felt really insulting and would have been unnecessary for that person. And then other people I've worked with where I really had to slow things down and simplify things quite a bit in order for that information to be internalized. So you just want to make sure basically that the information that you're giving it in a way that's appropriate with the person's developmental level. So whatever that looks like, and to not assume it's going to look the same for everyone. Not even everyone, like everyone with a mild ID doesn't look the same. That can look very different from person to person. So that you're just paying attention to their vocabulary, how they speak, their sentence structure, and then you're just matching what they're doing, and making sure that the interventions that you're using are built in a way, to fit that need. Augmenting interventions is also super helpful and important. It really can help deepen the understanding of the material that you're trying to give, and that can be all kinds of things. That can be use of art and drawing in sessions, or therapeutic games, or music, role play, just anything that can really help deepen the understanding of the material that you're presenting, and just really, again, helping with that internalization of the information. Use of memory aids to help address issues related to the attention issues that we talked about earlier can be really helpful, can really impact an individual's ability to remember the things that you've talked about in session in between your meetings with them, which is huge. So this can include a couple of different things. So sometimes I think it's helpful to have like a therapeutic agenda. And like for me, maybe that was just like on like just developing a piece of paper which just kind of talked about, these are the things that we talked about today, and kind of filling it out as we meet, and that the person can take home with them and then look through in between appointments to kind of remember, like if they had homework, like what the homework was, and so they don't just have to leave your office and remember all of that, because they're probably not. So something that they can take home with them is really helpful. Coping skill cards. So like if you're, say you're working on anger management skills with somebody, I used to take cards and just cut them, like have square cards that were just me making them myself using clip art that would just be like, I don't know, like Joe's toolbox with a picture of a toolbox. And as he flipped through, it would just be each skill that we worked on. And if the person wasn't able to read, then it's just with pictures that sort of symbolize and that we reviewed in session, and they know that's what that means of the skill that they can use, so that when they're upset, they can, or starting to notice that they're feeling frustrated or angry, that they grab those coping skill cards and can look through and to kind of have cues about, oh yeah, this is what I'm supposed to do when this happens. And social stories sometimes can be really helpful too. And this just talks about the therapeutic agenda that I just discussed. I just think it could be helpful, and so just something to think about when you're working with anyone that has intellectual disabilities. Involving caregivers can be just so important. I really can't emphasize that enough. They can act as that bridge, sort of between your office and home, so that the person can remember the things that they're supposed to work on. If the caregiver also knows, like, this is the homework that's been given. Like, for example, like I'm giving Joe like these coping skill cards, and it'd be really great if he could review them, like every night or whatever, or like a gratitude journal. And it'd be great if Joe could just think of like 3 things that he's grateful for today, like before he goes to bed. If Joe wants to do that, and wants the caregiver to be helpful and give reminders, that can be a really helpful tool. Also can be really helpful in conveying information and experiences from home or work, which the person might not bring themselves. It really just might not remember that something happened, but that could be really helpful to process in session. And so it's important to involve them, and then just be careful that communication is always directed to the individual, though, when you are including caregivers. So that you're not ever, I guess what I mean by that is that you're not ever talking about the individual as if they're not there. That if it's the 3 of you, that the individual is also like the person that's being spoken to, and that you're checking out with them and making sure that they're okay with the things that you're talking to the caregiver about. And it also can be a good opportunity to role model for the caregiver non-judgmental communication strategies, with the person, so they can kind of see how you're talking to the person or about their mental health symptoms, and it can be like a learning experience for them as well. Consider home-based treatment, because I think I know that that's not really feasible for everyone. Everyone can't do that, but if you can, it can be really helpful for a variety of reasons. One, it gives you the ability to observe them in their natural environment, where you might identify some issues happening that maybe would be helpful to address in therapy. And also, like, if you're meeting with somebody at home and you're practicing and role playing those skills at home, it makes it a little easier for them to generalize those skills to that natural environment versus just practicing them with you in your office. And we talked already about how important it is for a person to have a sense of control and comfort when they're meeting with you. And so just meeting with them where they want you to meet with them, whether that's at home or wherever that is, just can really help with that, just increasing their sense of control and comfort. And lastly, just termination issues. We talked a lot about like the grief and loss, and so the termination with you could be really difficult for your client. a lot of times that relationship that you develop, it just becomes a very special relationship to the person. They don't have sometimes a lot of those friendships like we talked about that are just really, that have that emotional intimacy and sort of unconditional positive regard to them, which you will be bringing that to your relationship with them, and that relationship can be very special for them. So you want to take a longer time to address any grief and loss that could be triggered, because you don't want your termination to trigger other mental health problems. You want to make sure that you fading out feels like a positive thing for them. And also, when you're sort of slowly backing out, you have more time just to, they can practice those skills and work on things for a little bit longer before they see you again, and a little bit longer, just so that you can be sure that they really have internalized those skills. And so by the time that you fade out, they're demonstrating the ability to use those skills on a pretty consistent basis, without that weekly touching base with you. So just the key points to remember is just it's really important to be flexible and to adapt the techniques that you're using. It's not really the modality so much, it's you being able to modify what you're doing to meet their individual strengths and weaknesses. And I just can't emphasize this enough. Psychotherapy is the best practice, and this is a really wonderful and rewarding population to work with. Just finally, on the handouts, if you download a copy, I just want you to know, like, I have all the references here that I think could be helpful. So, like, if you want to look up some things and get some more information, you can do that there. And I didn't have time to answer any questions today. This obviously ran a little bit longer, but if anybody has questions, please feel free. You can email me or get in contact with me, and I'm happy to answer any questions or be as helpful as I can. Thank you so much.